Well, it's Healthcare Unfiltered, and I am really honored and privileged to have Dr. Julie Gralow, the Chief Medical Officer of ASCO, who is an inspiring figure for our society, even before she assumed the role of CMO of ASCO. Julie, thanks for coming on Healthcare Unfiltered. I know that you are extremely busy and you probably get asked to be on gazillion shows. So giving me some time and giving my listeners some time means a lot to me and to them. Thank you so much for coming on.
Well, thanks for having me. I think this is going to be fun.
Yeah. And you'll get a t-shirt. I'm going to plan, we have to talk about that. But, Julie, it's interesting. I always think that careers are shaped for various reasons. And it's probably if all of us go back to medical school, it's hard for us to project where we'll be in 25 years after medical school. And I'm going to assume that when you went to medical school, you did not think you're going to be CMO of ASCO. But somehow careers progress. Tell us a little bit about you. I mean, how did this start? Why did you want to be an oncologist? I mean, what made you decide to even be a doctor, a cancer doctor? And how did you end up here?
Wow. Going back 30, 40 years now. I think even when I was in high school, I was interested in medicine. And so kind of went along the route, when I entered college of being pre-med, I was just intrigued by the science. I was good at math and science, and that seemed logical. When I was an undergrad, I actually was looking for a job opportunity to buff up my CV to apply to med schools. And I actually got a job as a lab tech in an oncology lab that was doing tumor immunology, back in the very early 80s. And so I saw that I was making monoclonal antibodies, and the lab was treating some patients with lymphoma with some of the first antibodies. And I could see that the science going on in the lab was directly impacting patients, that the research was so cool. So I applied to med school knowing that I wanted to go into oncology, which drove my classmates crazy, including my husband, who was my undergraduate classmate. We went to med school together because I knew what I wanted to do. But I thought I'd be an immunologist. I didn't know I'd end up in breast cancer. So I did allow experiences along the way to shape me. Then I almost accidentally got involved in global oncology. I mean, I was a new faculty member, and I was specializing in breast cancer.
What made you specialize in breast cancer? Did you meet someone that?
I was working in a lab during my fellowship on this really interesting new molecule we had found called HER2 that seemed to have some implication for breast cancer. And so I kind of used that as a way to take my clinic and see more breast cancer patients. And then we kind of bonded. As a young woman, I was interested in helping them with the survivorship piece, with the healthy lifestyles. In 1995, really as a very junior faculty member, the patient said to me, once our chemo's done in the adjuvant setting, we're told go back to your life and live it. And, we don't see the patients as often. And they said, we don't know how to get back to our normal lives. We've been through a lot. We have side effects. Most of us have been put through menopause, help us. And so, we chatted about it, started a lecture series called Living Well with Cancer, and then had an opportunity to participate in a triathlon as a group of cancer survivors, and were given free registration and training, and that ended up becoming something called Team Survivor Northwest, a nonprofit that we founded in 1995 that was all about helping women cancer patients get some physical activity in their life. And it wasn't a bunch of athletes. A lot of these people, one of my patients I was the most proud of at that first triathlon, she pushed her wheelchair around the 5K course.
Wow.
And she had the biggest goal and the biggest barrier to meeting that goal of any of the people, and she made it. And so it was all about setting goals, helping the support of other women cancer survivors around you. So anyway, that was breast cancer. Then the global piece was, there was a project being done by a nonprofit called PATH in the Seattle area on breast cancer in Ukraine. And they wanted a medical oncology expert locally as they applied for this grant from USAID to do this Ukraine breast cancer project. And I said, sure, I'll do it. I'll advise you. And then they got the grant, and that led to 4 years of project in Ukraine on understanding what was happening with breast cancer, and then working with the Ukrainian government, with the Ukrainian doctors on how do we improve, and connected with patient advocates in that project, which really was very inspirational. And I continue to meet with the patient advocates from Ukraine. Haven't seen them since 2017, but hoping to be able to go back there someday soon again. But introducing them to other patient advocates in the region and letting them learn from each other, support each other, helping them work with their ministries of health, work with their physicians, their national cancer institutes on improving cancer care in the region. So.
And with global, I mean, you're, Ukraine obviously is in Europe, but you've gone to Africa, you've gone to a lot of places, and as you do this, what do you do on these trips? Is it more education? Is it seeing patients? Is it what's the goal when you're going to spend a week, let's say, in Africa? What are you trying to accomplish? And you're doing this on behalf of the institution that obviously you were in Seattle, or this is more on a personal level?
Well, these international trips really vary very much. In May, I spent a week in Malawi, in Africa, and that was really bringing together patient advocates from Eastern and Southern Africa. The Ukraine project kicked off something I called We Can, the Women's Empowerment Cancer Advocacy Network. But then when I started going to Uganda as a result of the Fred Hutchinson Cancer Research Center partnership there, the Ugandan patients, the Ugandan Women's Cancer Support Organization, approached me and said, can we do a version of what you're doing in Eastern Europe and Central Asia, but do it for East Africa? I said, if you're inviting me in, let's look at what that might look like. It'll probably be very different from what's going on in Eastern Europe, Central Asia, but sure. So back more than 10 years ago, I think it was 2013, we had our first WeCan meeting in Uganda. We had about 10 to 12 countries. We tried every year to have another WeCan meeting, rotating through Eastern and Southern Africa. And the Malawi meeting was originally scheduled for March of 2020. And guess what happened? We got a little pandemic. So 3 years later, I've got a new job, and all of that. But we pulled together the patient advocates from, I think, 12 African countries. And we brought for breast and cervical cancer, and we had some education. We had local experts meet the advocates and speak to the advocates, and we had the Ministry of Health kick off the opening ceremony. So we're educating and empowering the advocates. We're introducing them to their local government officials and physicians and healthcare providers. But most importantly, we're creating a network where they can support each other and show each other what they've done and best practices and how they had successes. So that was what I did, that week in May of 2023 now, which was really thrilling to see, going back to 2013 when we had the first WeCan meeting in Uganda, and seeing how amazingly developed and professional the achievements that these patient advocacy groups have made, and thrilled to see that success and to be able to support them. I'm trying to hand it off to them. I think they've grown, that they can take this, and I can just give them some broad support at this point. But But that's one of the things I do internationally.
So then I mean, you're doing the global stuff, you're doing research, you're taking care of patients with breast cancer, and somehow the CMO role at ASCO opens up. And we all know Rich Shilsky was the first CMO of ASCO when the organization decided to recruit this. How did this come about? Did you think about, maybe I want to do this next? Did they pick up the phone and call you, hey Julie, would you look up at this role? Like, how did this just come about? And maybe what how did the interview process go? We're always curious here in the oncology community. What does that look like? Like, do you actually have to come with a pitch slide deck and say, this is my vision as the CMO? Whatever you can share with us, just to get an idea.
Yeah, well, I was very comfortable in my career and where I was. I had spent almost 30 years in Seattle at the University of Washington and the Fred Hutch. And I was executive officer for lung and breast cancer within SWOG. So I had, my clinical trials piece. I was leading the breast program within our institution, and I had a great program, great faculty and staff and patients, and the global piece was going well. And so I saw the announcement that Rich was stepping down as ASCO's chief medical officer. And I looked at it and I said, well, this would be a great job for somebody. And I didn't even think much more about it. I had been in Seattle for 30 years and, but was not really looking to leave. But then I actually got a couple of text messages from some of my former mentees or faculty that had seen it, and they said, this is you. And so after getting a couple of those, I said, this is great. And so, I wasn't ready to leave Seattle though. So I emailed Rich Shilsky and said, hey, I'm not throwing my hat in the ring, but can I talk with you about what the job is? And then I emailed Cliff Huttis, our CEO, and said, I'm not throwing my hat in the ring, but can I just talk with you about your thoughts about this? And then after talking to the two of them, I said, well, I might as well, explore it. What can it hurt to explore? I was still trying to figure out how could I possibly leave my current job, and so started interview process with key people within ASCO and on the board, and became the finalist. I think a large
So what kind of questions do they ask you? Like, give us like a couple of questions that, the board or folks ask you.
Well, so the departments that this role oversees are Centra, the Center for Research and Analytics, Care Delivery, Policy and Advocacy, and International Affairs was being moved over under this position. And so, I kind of have the street cred with the research, moving up through the cooperative groups, being an executive officer of SWOG. But they asked me about that. What was my vision for the future of the TAPR trial, for research being done within ASCO, for how ASCO could support research in our Centra group. They asked me a lot about the international piece, because even though ASCO, a third of its members are international, we had a small but mighty international affairs department, but we really hadn't exploited it. Although in the previous couple of years, the ASCO strategic plan had added a pillar that was make a global impact. And so now the board, our executive leadership team was really focused on how could we make a global impact. So a lot of the questions were about my vision for how ASCO could play a role, not just in the US, which is a lot about what care delivery and policy and advocacy are about, but also outside of the United States. I practice in an academic setting. I'm not an expert in the business side of oncology, in the community side, but they did push me on that. How am I going to help represent our members, who might be out in community practice? And so one of the pieces I brought an answer to that question was that, I'm actually on the board of a rural access hospital in Washington State. That's also kind of just a coincidence of, we have a house up in remote Washington on an island, and the island was looking to build a community hospital. They just had a clinic at the time. And one of the main goals of some of the people pulling together this project, because they had all had family members who had been impacted by cancer, was to be able to deliver chemotherapy on the island. And how could we do that in a safe way where we wouldn't have a full-time oncologist on the island? And was that responsible? And how could we connect? And so that was very interesting. We built it. We way under budgeted for the infusion room. We didn't think the need would be as great as it was. And the patients loved being able to stay on island. Even if their oncologists were off island, they could get the bulk of their treatments in the infusion room on the island, not have to take the ferry off or fly off island. And so that gave me an exposure to, I'm still on that board, to how does rural medicine, where we have 3 oncology certified nurses and a medical oncologist who comes over about once a week, to make sure things are going well. So it gave me a bit of exposure to a very rural practice and to the business side of how did we make that infusion room work and all. So
I always say that in the interview process, you either start liking the job more, or you kind of that's what, you're interviewing them, frankly, like they're interviewing you, right? You want to know if this is what you want to do as well. And obviously, as you interviewed, you continue to like it because that's where you are right now. What kind of questions did you have for them? Like, what reservations do you have? Because to be successful, obviously, you have certain things you want the organization to give you back, to represent well. What kind of things you really wanted to see in place so you could position yourself for success?
Yeah, well, one of the things I was interested in is the ability to be innovative and to do pilots of some new things, and not have to go through all of the approvals and all of that typical academic institution would have. And Cliff assured me that we can move on a dime, really. We present to the board, we present to the executive leadership team, but if it's something where we say, yeah, let's go try this, it happens. It just happens quickly. And the thing that I didn't have to ask about, but that was very, very important in my decision, was about the ASCO staff. I was actually shocked to learn that we have about 500 staff. And I knew a lot of them. I had been on various committees over the years, and I knew ASCO. Really, I've been loyal to them since 1995 when they gave me my career development award, and they really made my career. I was on the public affairs committee early, was the chair of the communications committee, worked on resource stratified guidelines, and then led a task force in international affairs. I was also on that committee on academic global oncology. I knew the ASCO staff and how great they were and terrific they were. And I knew I would have great support. So I didn't have to ask about that. I knew the people that I'd be working with and was thrilled to think about, working with them in the future. The hardest part was that my job is based in Alexandria, Virginia, and I still live primarily.
That was my next question. As you thought about this, and obviously you loved the opportunity, you were in Seattle, it's in DC, in Virginia. Was that ever a concern to you?
That was the biggest drawback, actually, was the distance, and could I really do it? And although we have a lot of flexibility, especially COVID offered even more opportunity for remote work, if it could be done, our employees are allowed to become remote workers. But the 5 members of the executive leadership team, our job is based in Virginia. So we're expected to have a presence here. So that was one of the hardest parts of the decision, was really the distance. And we were in the middle of a pandemic at the time. when I took this job as well. So, but it's worked out. I'm here in my office in Virginia
So do you
today.
go back and forth a lot? Like, do you alternate Seattle versus Alexandria?
Yeah, I do. I'm here 1 or 2 weeks a month. I can do the rest remotely. And I have a nice apartment here, so it's very comfortable when I come here. It's 2 blocks from ASCO headquarters and 2 blocks from the metro station. So I just made it as easy as possible to come and not think about it. I have, a nice place to stay, and yeah, and I'm very productive on long plane flights.
So yeah, well, that's that. I mean, you have a lot of miles, let me tell you. But what does a day in the life of an ASCO CMO look like? I mean, I think that it seems like you're obviously overseeing 4 major organizations within ASCO that you just mentioned. But how do you spend your day? And I have to ask about the life family balance, just because with so much travel in Seattle and this, how do you kind of shut down and just try to get a little bit of a respite from it all, because you have a very, very busy lifestyle. At least that's what we're seeing on the outside.
So the life work balance piece of it. So I don't have children, so that makes it a bit easier. My husband still works in Seattle. When the pandemic hit, he went 3/4 time, so he could maybe travel a little more, be in DC with me a bit more. He came to the ASCO annual meeting, and then we went to the bio meeting afterwards, and then came down to DC together. So, he travels with me sometimes. And I really think our house up on this island that I talked about, where I'm on the board of the hospital, that, which we've had for more than 20 years, that's our rest place. It's right on the water. It's beautiful. We can hike, in a national park right from our door. We have a boat we could go out in. It's really easy to decompress. So I can decompress quickly when I'm up in a beautiful place, on the water, and then get back to work on Monday again and, go full force. But the work-life balance, I mean, finding time, just blocking out days where it's like, I won't even turn on my computer for 1 or 2 days when it's, a weekend and we're up on the island.
Yeah. And how do you spend what's a day in the life of a ASCO CMO look like?
Well, it's very different, and I am the medical voice for ASCO. Cliff is kind of the business side of ASCO. And then our presidents, also we use them and their skills, et cetera, to be another voice for ASCO. Something that I did for the first time ever a couple of weeks ago was I testified in a House subcommittee on drug shortages. And so working with our policy and advocacy team and then our marketing communications team, we created testimony, went in front of the Health Subcommittee of Energy and Commerce and testified on drug shortages and what legislative changes we might be able to make that could impact the drug shortage problem. And specifically, it was about what we might introduce in the Pandemic All Hazards Preparedness Act, which is an act that's been around for quite a while, but it needs to be renewed by August. And so could we slip in some things related to drug shortages as a national security threat that could be put into that package? So that was a fascinating experience. I mean, the last 2.5, 3 months, I've done probably 30 press interviews on drug shortages. I mean, when hot topics come up, I'm the medical voice and I speak for what ASCO's recommendations are to impact whatever the issue is at the time.
It's a perfect segue in terms of what is the hot topics that are really happening. But before I get into a couple of the hot topics and focus a little on drug shortages, I always try to figure out the relationship between ASCO executive, like, Cliff, you, and others, and the president of the society. I mean, obviously, let's say Eric Weiner, who is the outgoing president. What does that look like? Does the president come to you, because you're the medical voice, so of the entire ASCO, but then the president of ASCO is the one for that 1-year term. What does that relationship look like? And when do you go, for example, to the president and say, hey, let's do this, versus when he would come to you or she come to you and say, maybe this is what's going on?
Well, I think there's a good back and forth. Several years ago, we recreated the president position, so it's really a 4-year position. And so we spread the work, because the president is being asked to speak everywhere, right? We spread the work across 4 years. So you're the president-elect, the president, the immediate post-president is chair of the board, and then there's the post-president. And so it's spread over 4 years. So luckily, the 4 years of presidents, the 4 presidents at any given time, there's only one who's the true president. They all are much more engaged with each other, and we can carry themes, from president to president much easier. The president really is also representing all of our members, and the board is too. So, we take our direction from the board. Any big new programs or things, come, we present to the board, they give input, or they bring it to us. I mean, Eric Weiner, I've known forever. We were both breast medical oncologists, both involved in the cooperative groups. He picked his theme, partnering with patients, the cornerstone of cancer care and research. And my job was to support him, but also to help with that theme, partnering with patients to come up with ideas, have back and forth. Lynn Schuchter is our current president as of the end of the ASCO annual meeting. She is very interested in, the supportive care and palliative care. So I think her theme is the art and science of cancer, from care to comfort. And so I'm looking for opportunities to bring the palliative care piece, the supportive care piece in to the annual meeting, but also things all year that will build up her theme, and then continuing over Eric's theme,
Right.
All of the presidents in a row, the whole equity, diversity, inclusion. When I started, Lori Pierce was our president, and we did a lot of work. Her theme, equity, every patient, every day, everywhere. I mean, that's still informing pretty much everything we do. So it's a back and forth. We support each other, and help spread the word, make sure our messaging is consistent too. We're all representing ASCO and our members. That's what, we're a professional society. We're representing our members.
So as part of this representation, obviously you deal with a lot of these hot topics we talked about. And I think, there's so many that we could talk about, obviously, but I really want to focus maybe on a couple of them. It's, you already alluded to it, the drug shortages. It's hard not to talk about this, obviously. It directly affects patient care, right? I mean, there's so many other things, but this affects prescribing treatment that could be curative in certain circumstances. And you switch on Twitter every day and people talk about rationing care and all of these things, which you do in low middle income countries probably all the time, or we're not used to this in the United States. And some of these drugs, like for us, it's like, we think it's silly. How could you be short of carboplatin or cisplatin? Like, how is this a possibility? So you're faced with this as the medical voice of the society. What do you do? I mean, you can't make drugs. You can't, I mean, I don't know, like, obviously you have to issue statements of, I guess, disappointment and things like that. But how are you able to handle a crisis like this and try to hopefully resolve it, or pressure folks who are able to resolve it?
Well, there are many ways we can tackle it. First is to help understand what's happening and educate our members and the public about when we first started hearing about sites not being able to get access to these drugs, what was going on. So researching what had happened, and trying to figure out how long we thought this would happen and how severely it was affecting our members, because we were hearing kind of just word on the street that certain sites weren't able to get these drugs, but others thought that they had plenty to last a few months. So understanding what was going on and then educating, trying to be transparent about what was really happening. And then coming up with regular updates. So, this is changing on a day-to-day basis. So quickly created a web page where we could put, here's what's happening. Here's the testimony now that we're giving to Congress about maybe some legislative things that we could propose that would be fixed. We've started developing guidance for specific cancer types that rely heavily on the platinum agents. And what do you do if you don't have platinum agents? What are acceptable alternatives, or which ones do you really need to save the platinum agents for because there's no good substitute? So that guidance is being added. We came up with ethical principles for how you would decide how to ration, if you will, and that's on our website. Drug shortages are nothing new. We started work on this, I think back in 2012 was one of our first statements that was written about drug shortages. And over, a period of the next several years, a lot of the childhood leukemia drugs, all of which were off patent, cheap, you're shocked that we can't get these basic drugs. They kind of rotated in what was, in short supply. And childhood leukemia, if you can get these drugs, you get very high cure rates, right? So it's a small number of patients who are impacted, but a huge impact because with the full regimen, you had high cure rates. So we've been working on this. Even 2017, 2018, there were a series of some summits that we and other organizations participated in where we came up with recommendations to help, with the drug shortage situation. And so this is the most severe that we've ever seen and impacting the most patients that we've ever seen. But we've had drug shortages in cancer and beyond cancer, for a decade or more. And it's mostly an economic and a market problem of what happens when drugs go generic, especially the sterile injectables, because they require, a much higher level of production and quality. A pill, is not quite the same in terms of all the monitoring and the sterility and everything is with these sterile injectables. And so we went back with this drug shortage and went to our recommendations from 2017, 2018, looked at them. Almost none of them had been enacted, and pulled them back out again, dusted them off and came up with, okay, these are still our recommendations. There are legislative, there are regulatory, and there are market things that we can work on. And then going in front of Congress or to the FDA, or, we're trying to figure out what our impact can be at the market level as well, at the economic level. It's fascinating that in the United States, we pay the highest amount for the on-patent cancer drugs, all these, and we pay the lowest amount for the generics out there because of this free fall where it goes generic and companies compete and they underprice each other, and then they underbid to the point where some of the highest quality manufacturers drop out of the market because it's not making them any money. In Europe and other parts of the world, these generics cost more, not markedly more, but they pay more for these in exchange. They make long-term contracts. Lots of times it's the government buying, so they can make a long-term contract. They make sure to spread it out over several manufacturers, so that there's some stability if one of the plant goes down. We need to look at some of those strategies for how we incentivize high quality manufacture and maybe bring some of it back in the US again so that we're not so vulnerable and that we have redundancy in the system so that not only are there multiple manufacturers of a given drug so that if one plant goes down, it's not this crisis, but also where the raw materials come from. That's what this crisis is all about. It's, the raw materials that go into making the platinum agents. It was a plant in India, these active pharmaceutical ingredients, API they call them. And the FDA doesn't have the legal authority to demand to know where a given manufacturer is getting the raw materials from. If they can ask, but they can be told proprietary information. Well, it turns out that we didn't have redundancy in the system for the platinum agents for where they got the platinum raw materials from. We knew we had like 5 manufacturers that we had approved to make the platinum agents and import them, et cetera. But we didn't know that this one plant going down was going to impact basically all of the manufacturers that are approved in the US for the platinum agents. So, there's things we can give more transparency at the FDA level. We can give incentives for high quality manufacturers. We're talking about stockpiling, but whether that be at the government level, at the institutional level, or at the manufacturer level, how does that work? How do we help support the good high quality manufacturers to be able to make a little bit of profit and off of these drugs?
Yeah. Where do things stand now? Like today, we're taping this for listeners. This is airing on July 11, but we're taping this about 10 days before the end of June. Where do things stand in terms of drug shortages today?
We have a severe shortage of cisplatin and carboplatin. As of June 27th, we're talking. The FDA has approved a new manufacturer to import from China, cisplat. I don't think I've seen, a major improvement there. The other manufacturers are trying to ramp up. They're trying to eke out. We are reporting each time more cis or carbo is available for purchase. ASCO is tweeting it. We're putting it on our website. We're saying, here's the company, here's the vials they have, go at it. It's really severe still. And,
do you see it? Do you see it resolving in the next couple of months, improving?
I was hoping we'd have to scrimp and save, and use some alternative regimens through the summer. I'm not convinced of that right now. We don't know when this plant in India will be up and running again. That gets to some of the transparency of, exactly what were the issues and what are they doing and do we have an estimate? So there are also a good 10 to 12 other cancer drugs on the FDA's drug shortages list now. Nobody's saying they can't get them right now, but they're on the drug shortages list because there's something going on. There's a problem with a plant, or there's been a report of some issue where this could immediately become a problem. And what we really need to do in the short term is shift it to knowing as much ahead of time that this is, so we can approve imports from other countries. Rest of the world has cisplatin and carboplat. They're just getting it from other manufacturers. So if you had a lot of advance notice, you could do some temporary importation approvals in advance. If you, had redundancy in the manufacturer and the raw materials, you could see what the impact would be of one plant going down.
Does ASCO have, or do you have, on behalf of patients and society, can you, pick up the phone and call manufacturers and say, hey, maybe, if there's a way to wrap up a little bit more, I don't know. It just seems to me that maybe there's a way. I don't know.
Yeah, we're not directly calling the manufacturers. We know they're working, as hard as they can. What we're working on, one thing we are working on is we sent letters to all the payers saying, hey, we're hearing from our members that there are pre-auth problems going on when a substitute regimen is being proposed for a patient, because, the cheapest regimen most likely includes a platinum agent. Those drugs are cheap. And now a different regimen is being proposed because platinum's unavailable. And we were hearing from our members that there were pre-auth problems. So we wrote to all of the payers and said, hey, let's talk about this. This is an issue. And it's on their radar now, because what happened was they just had all these algorithms and it said, for this disease type, you use this, and this is the preferred regimen. And when that wasn't what was being entered, it was what. So, that's the kind of thing we're doing, is to try to eliminate that. And we're trying to
the pre-auth is another thing, right? It's another hot topic that you're tackling right now in general.
Yeah. It was one of our 3 or 4 high priorities when we had our advocacy day on the Hill back a few months ago, was tackling pre-auth and streamlining it. It's obviously a big headache for all of us in clinical practice. And what can we do when it is evidence-based? I mean, we do need a system in place. You don't just go off and use non-evidence-based expensive regimens, right? But when you're using evidence-based approaches, we shouldn't have these big delays. And the pre-auths are not just in the drugs, right? They're also in the scans. I mean, the scans in many ways was, is sometimes a bigger problem, because they're just being flat out denied, and then the whole waiting on the telephone to try to get somebody to see it. And the patient now is having symptoms and you need to see what's going on, and you can't just go and do it. So that is a big strategy, and we're working on it, potentially with some legislation to try to help with that.
So a couple of other hot topics, ASCO probably, or you have to deal with, is one comes to mind is AI, artificial intelligence. I obviously AI is here to stay. It's not clear to me today the impact of AI directly on clinical care, diagnostics, therapeutics, all of that stuff, as well as really, I think you're frozen, Julie. Oh, you're back. You froze a little bit. As well as the impact on clinical trials and things of that nature. But, one of the things that intrigues me is that any patient could go into ChatGPT or other engines and type whatever they want, and they get information. And I still don't know how accurate the information will get. So when ASCO looks at AI and directly how this is, affecting or impacting patients as well as oncologists, do you feel you have, as a society, tried to look into it, or are you just in an observation mode right now? Where do you stand on that?
Yeah, good question. I just came out of our vice president's meeting. Our VP of journals, is talking about what our journals are doing in terms of the whole AI thing. What are we going to accept? I think we need some standards across the industry. ChatGPT is not a co-author, but we know people will be using it, to form some basis of starting papers, for example. So we're struggling with how do we deal with it in our abstracts and in our publications. With respect to patients being able to go into ChatGPT and, asking questions, they've been doing it with Dr. Google for a while. Now, Dr. ChatGPT, which happens a lot faster and summarizes a whole bunch. I do think we have to be very careful, about the accuracy of what's coming back out. It is pretty impressive, though. I've played around with it and, asked it questions, and, I think we're going to have to tackle it. I saw, not remembering, who said it, so I'm not going to be able to credit, but on Twitter I saw, that ChatGPT is not going to replace oncologists, but oncologists who use AI are going to replace oncologists who don't. So I think, that does make sense. I mean, I think it's here, and it's not going to go away. And so we should embrace it for what's good and then speak out for the parts that are potentially dangerous and just embrace it, make our lives potentially easier.
And another thing I'll have to ask you just in a few minutes remaining, because I want to be very cognizant of your time. I mean, ASCO obviously is a medical society, represents everyone, and I'm pretty sure you try to stay as far as possible from politics, just because politics, unfortunately, in the US have become very divisive recently. But I don't know, how do you navigate this? So, for example, I know that you've been trying to address abortion issues as an example, and abortion could be a very heavily politicized question, which I believe is going to come up in the presidential debates and things of that nature. But where you sit at ASCO, which obviously you represent people who believe it's okay and people who don't believe it's okay. How do you strike that balance, stay out of politics, stick to the ability of representing the society in a way that helps patients?
We have a set of guidelines for any kind of hot topic like abortion, like climate change, like, things like that. We have a set of guidelines that we go through, does this impact our members and or their patients? What is the piece related to cancer that is part of this issue, and can we, by speaking out, actually play a role? And so with the whole abortion issue, we stuck very tight to how does it impact cancer patients. And so, a pregnancy at diagnosis, so that occurs during treatment, expanding it a bit to the whole fertility preservation piece and the creation of embryos, et cetera. And so we spoke to how does it impact our patients, and their healthcare providers in decision making about giving safe treatment. And so saying, abortion is evidence-based when you have a new cancer diagnosis and you can't give these drugs. They're not safe to the fetus. And so it should be an option discussed and presented with the patient. And so we took that tack, that we're specifically talking about it in the context of cancer care. Now, and that kept us in our own, window. We didn't go beyond that. We're having a series of 3 webinars with the National Cancer Policy Forum, starting in July, addressing cancer and the Dobbs decision, where we're going to talk about all these issues. So when we stick to impacting our patients and their providers, we aren't trying to go beyond that. I think we're respected, and I've actually, I've been surprised. We've worked with some groups that have presented scenarios of patient situations to, people in red states, blue states, whatever. And when they present the scenario of a young woman with leukemia, and at the time of diagnosis, they do a pregnancy test, and she also finds out she's pregnant. But she is very ill, and we need to get her in and get treated very quickly. And so, abortion is an option at that point. Most people, no matter where they're from and their political beliefs, actually said, "Oh, didn't think about that kind of a circumstance," and would be willing in that sort of a situation. The patient's life is in danger, and the baby needs a mother to be able to raise it, that they would be able to think about that differently. So that's kind of interesting feedback, that even groups that were, very opposed to abortion more broadly would accept that that was the scenario that they could support. So,
well, you're doing really amazing work, Julie, in such a really short period of time. I mean, I think you're not only elevating the level of the society, but you're really representing us everywhere, globally and locally, and you're inspiring a lot of young as well as future generations of oncology. Is there anything I should have asked you that you'd like to leave us with? I know that, you know, I'd like to keep talking to you for the next 2 hours, but I know that the time is limited. So is there anything I should have discussed or talked to you about in the short period of time?
Well, we'll keep our conversation going for sure. I guess I just want to really leave with the message that, you know, I want to hear from our members. We are here to help oncologists better serve their patients. So I love the interactions and the ideas. We can't do everything, but just knowing what the issues are, you know, my email is really easy to find. It's julie.gralow@asco.org. But love hearing what's going on, how can we help, what are the issues, where do you think we might be a little off target, or, you know, where we should direct more of our efforts. I mean, you know, we're a professional society, we're here to serve.
Well, Dr. Julie Gralow, thank you for coming on Healthcare Unfiltered. I really appreciate it, and thank you so much.
Thanks, Jody. Looking forward to getting my t-shirt.